Good morning, Austin. Thank you so much for joining me to have a conversation about the impact of drugs and alcohol on people in Ireland. Can I just start by asking you to introduce yourself, what you do for a job and where you are in the world?
Okay, my name is Dr. Austin O Carroll. I'm a GP in Dublin. My specific expertise is probably in working with marginalised groups. I founded Safetynet and GMQ, two primary care services for homeless people and for other marginalised groups. And GMQ in particular specialises in addiction treatment for people who are homeless. I also founded the North Dublin GP training scheme, which trained GPs to work in areas of deprivation with marginalised groups. So that's probably my area of expertise.
But importantly, you're building capacity within the medical workforce, so there's more people with those skills.
Yeah, 95% of our graduates are actually working in areas of deprivation and with marginalised groups, and 55% actually working with either homeless drug users or ethnic minorities or travellers. So yeah, that capacity has been built up. It's a model which seems to be working, which has been replicated in the UK at the moment as well.
Fantastic. So it's April the 30th. We're about 6 weeks into lockdown. A lot of people would think about Dublin as kind of drinking, partying, wealthy, affluent.
Yeah.
Actually may not exist. There was too much of a homeless problem. But I know from visiting that there's a problem with drugs, and there are some people in Ireland who drink too much. So what's been the impact so far of COVID-19, first of all, on the population you work with?
I'll start with homelessness. I'll probably talk in general because I think sometimes it's worth, because obviously we believe the social determinants model. It's the effect of everything that's happened in COVID on eventually on addiction. And in fact, it's a really good news story in Dublin. Homelessness and drug addiction and alcoholism are probably inextricably connected in Ireland. Like 70% of people have a drug addiction problem, 30% of an alcohol problem. Of homeless people have an addiction problem, and around 30% of an alcohol problem. So the response has been very interesting. What happened was when COVID came along, so I should clarify, homelessness also is so endemic in Ireland and so severe over the last 10 years. It's probably, along with health, with the two issues that brought the last governments down. So that's how severe homelessness has been the last 10 years. So it's almost like in 3 or 4 weeks, we have solved the main problem of homelessness. It's incredible. Firstly, what happened was we hit the ground running. We have Safetynet, which is a mobile health unit for screening people. So as soon as someone who's homeless has symptoms, we were able to screen them within 2 hours. And within another 2 hours, we got them into isolation, into a new accommodation we got that we were able to isolate people who were symptomatic. And when they're in isolation, we have them monitored with both nursing and doctor care. We then also identified everyone who's homeless we basically created a point scoring system to identify vulnerable homeless people. And we got 450 new accommodations. And basically now everyone who's over 60 in homelessness has got their own room, and everyone under 60 who has significant medical morbidity has their own room, and so that they can cocoon away and keep themselves safe.
Amazing.
We've also identified a number of hostels that were not technically overcrowded, but had up to 8 people in a room, and we basically decanted up to a third to half out of those hostels. What we did in terms of addiction treatment was, the big issue was, will people stay in isolation if they're addicted to heroin? And we knew there's a lot of people on heroin who weren't on treatment. And also we have a massive benzodiazepine problem on the streets, people taking up to 60 tablets a day. And so we had a waiting time of 12 to 14 weeks for methadone. And we got permission overnight to reduce that down to a 2 to 3 day.
Amazing.
Incredible. So bureaucracy crumbles in face of a crisis. I mean, I don't know if you know, the Chinese for crisis means opportunity with danger. And I think this really captures that in this case. And we also started people on benzodiazepine maintenance courses when in treatment with 30 milligrams. We found 30 milligrams actually prevent most people going out on the street when in isolation. And we also addressed did a number of Librium detoxes. Overall, we moved around 1,200 people, and the results have been phenomenal. we had made a model of how much we expected COVID to be affecting the homeless population. And we had expected that at this stage there would be around at least 4 to 5 deaths and at worst 20 to 30 deaths. We have no deaths to this stage. We reckoned we would have around 300 people who were either COVID positive or suspect at the height of the thing. We'd only around 40 at the height of it. So it's, but that was also very interesting. We got a letter from 2 local casualties, which said that they had noted the low rate of COVID in the homeless population, but they'd also noted that the attendance at local EDs for other medical problems had plummeted. And a lot of those medical problems would have been drug related. So we've been discussing how we manage this as we go along, because obviously we're continuing to get people onto methadone treatment. But the interesting one is we have, as part of our support for people in isolation, we have 2 local drug projects who go around, manage their, bring their medication, get their social welfare, and work with them in terms of harm reduction. But they're reporting back that the people on the benzo maintenances are doing extremely well. So we're now considering how we manage this, and do we continue these maintenances going forward, and do we, at what, to what level do we reduce it?
Have people come in seeking benzo maintenance because their traditional benzo supply has dried up?
No, people who come off the street, we've been doing benzo detoxes. We have a very structured detox where you have to do 2 weeks work with a community worker, preparing diaries, doing relapse prevention work. And then we start as high as 40 milligrams, reduce basically over around 5 months, where you're doing intensive work as you do that time. We have noticed more people coming in for the benzo detoxes. We traditionally haven't done benzo maintenances for people just coming off the street to us. We would tend to offer this detox. What we do is, if someone has failed 1 or 2 detoxes, we'll then consider them for maintenance. But we have seen more people coming in for detoxes, absolutely.
How have you managed the issue of offering people unsupervised doses and takeaways of methadone, so they're not coming to clinics and pharmacies every day? Have you reduced the frequency of pickup?
We have reduced the frequency of pickup. So someone who would have been on daily dispensing, we probably go to Monday, Wednesday, Friday dispensing. And depending on, like, there's a few people, obviously the people we've initiated, we've kept them very tight. Where people are in isolation, what we've done is that we've got it collected on a daily basis and delivered on a daily basis. So there's no supervised consumption, but you're only getting a daily dose. So that's where...
It is almost inconceivable that you go from a 14-week waiting list to home delivery and alternate day, takeaways and the benzo detox. Probably everything that so many patients and practitioners in Ireland would have wanted for decades. And no amount of legislation or lobbying would have ever got you there. So I love your description that it's the crumbling of bureaucracy gives that opportunity. It's it's such
my own take on it is that one of the rationale given out for this the high waiting lists was the need for governance and the need for safety, in particular the issue of maintenance leaking out in the streets. So there's this fear of methadone going on the streets. And I do think there's this, this idea that doctors first do no harm. I question that, because I think that's often used to avoid doing good. And,
controversial, Austin, controversial.
But I'm going first. I've often seen that used to block the provision of services to people who badly need it. And I'm not saying we shouldn't keep things as safe as possible, but I do think there's always a balance between risk. Now, come on, being honest, every single ethical intervention actually is a risk of whether you do the right one or wrong one. So, I mean, the reality is we try and avoid doing harm, but that should, that to me, I always think the one that I always find the most ironic is people who are drinking alcohol, and then they come in and they're drinking, and next thing their methadone doses dropped massively. And yeah, that's to reduce harm, but then they go out and score, and we all know they go out and score. So
yeah, for people who are opiate dependent and alcohol dependent, when they come in for an alcohol detox, I'm always very keen to thump their methadone up, because I think that can sometimes be protective for them not returning to drinking. And
yes.
And the idea of harms is doctors are only thinking of the harms that affect them personally, like patients dying and going to coroner's court. We don't think of those other harms. And of course, now when we've heard this from the UK is, well, yes, there's a risk of methadone leaking into the community, but then there's catching COVID and dying. Well, COVID wins, methadone takeaway rules.
Absolutely, trump card. Wrong term to use.
I was going to say, anyway. So that sounds like there's been the most amazing response, great opportunity. Which of the things that have happened now do you see as being part of treatment moving forward? You're going to show positive outcomes.
I think there are two big ones. I think the biggest one, believe it or not, is the housing. It's almost like we've had the biggest housing first experiment, and I think housing is a major part of this improvement. So everyone agrees we cannot go backwards on the housing. In terms of the medical treatment, absolutely the reduction in waiting time is key. And I think the issues of benzos, we're feeling our way along on this one at the moment, but I think definitely this is an issue that hasn't been grasped. The nettle hasn't been grasped. And now that we have the option, I think we need to look more at that idea of who's suitable for benzo maintenance and who is suitable for benzo detox. We only recently opened up a stabilization center, and it was a good time to open it up. And I think we probably need more of those services going forward, because that has been useful during this period as well.
The benzodiazepines is interesting, because I think many services just put their hand up and go, that's adding a level of risk and drugs for diversion that doesn't offer any benefit. You're being given a unique natural experiment to be able to challenge that. And it sounds like you're going to be able to make a very good economic argument. If there's less emergency medical treatment, there's less people using drugs, there's probably going to be less crime. It's just not good for public health. It's good for the economy. It makes sense.
It does, and I also think we're going to monitor people's ability to hold down accommodation as well, because I think that will also be another factor that we'll find. We previously looked at our methadone maintenance, and we found people, rough sleepers we take on, within 80% of them within a month, their accommodation status improves once we take them on for methadone maintenance. And I suspect we're going to try and follow that up for benzo as well and see if that'll improve as well.
I mean, Austin, I've probably done about 20 of these interviews now, and some of them have been positive and some of them have been a bit miserable. I haven't spoken to anyone who comes close to talking about the implementation of effective innovation that has stripped out all expectancies, housed people, got them on treatment, trying new things. It must be incredibly rewarding. I'm wondering how you guys are staying safe. Like, I saw a mask earlier. Are you PPing all the time?
No, we're practicing safe distancing is the main thing. What we're practicing, one of the things we got earlier at the message that the two key factors are distancing and hand washing. And we're only using PPE when we're in close contact with patients. And when I say that, is like, I mean, for example, in most of my surgeries, the patient is good over 2 meters away, and we are discussing the distance. We're obviously in teleconsultations most of the time. In the homeless sector, it's much harder to do teleconsultations, but we're really practicing the distancing and the hand washing. And then, if I am in close contact with patients, we will wear the PPE, but not the full PPE, just the apron, mask, and I tend not to avoid the gloves, because unless I'm actually examining the patient, because you tend not to wash your hands if you've got gloves on, and gloves pick them up and spread it. Whereas if you haven't got gloves on, you wash your hands much more frequently.
That's an amazing takeaway point to leave on. Don't be fooled by the protection.
Let's throw one more takeaway in. I do think one of the big things was when we set up this response, I'm sort of the clinical lead for the response at the home.
Oh, Austin, I've lost the audio.
Apologies about that. Someone rang in. I just off. I was saying one of the things that we had was, from the very start, we had both the health, housing and housing agencies sitting in the one room together addressing this crisis, along with the voluntary agencies, both medical and housing. And I think it's that collaboration has allowed us to bring this bureaucracy down and actually achieve these outcomes.
It's amazing. Look, congratulations. It's so good to get any positive news at the present time. And I mean, hopefully other people watching this can go, You can go from 13-week waiting list for 48 hours. You can house everybody who's vulnerable. You can do it.
Exactly.
Austin, thank you so much, really.
Pleasure, Adam. Thank you very much.
Yeah, really, stay safe.
You too. Have a good. Take care, Adam. Bye.
Bye.
Right, and then I see the disinfectant where it knocks it out in a minute, 1 minute. And is there a way we can do something like that by injection inside or?
So the question that you chose to ask, will it be better where we're going? And though the answer I don't know for a fact, still my heart is saying, oh yeah.
Still just taking it one day at a time. Still don't know what I'm trying to find. Really I don't mind, cause I'll be fine. Yeah, I'll be fine. Yeah. No longer focused on yesterday, and I don't care, the rest will say whatever they want, what's left to say.